All right, and now, Dr. DeCleva, do you see the full slide?
We do.
Great, wonderful, thanks everyone. Well, thank you to Dr. DeCleva for the very kind invitation to participate in today's conversation, and to my fellow presenters, Dr. Taminga, and to all those who have been working so hard behind the scenes to make this conference possible. It is a pleasure to be here and to reflect on two topics that make each and every day for me incredibly rewarding. First, the question of how the human brain, a roughly 3-pound gelatinous collection of 100 billion neurons and over a quadrillion connections, gives rise to joy, to fear, creativity, despair, and the ability to ponder our own existence. And second, shedding light on this most mysterious of organs to ease the suffering of those who seek our care. These are, at its core, the fundamental tenets of the field of neuropsychiatry. Just to say, I have no financial disclosures, and my academic funding is through the generosity of the Peter O'Donnell Jr. Brain Institute. To fully appreciate where the field of neuropsychiatry is headed, I believe it is important to know its beginnings. No story of neuropsychiatry would be complete without mention of Hippocrates, who, in antiquity, championed the view that the brain holds a key role in human thought and feeling. In the centuries that followed, several physicians, scientists, philosophers would build on that very notion, culminating in the birth of a proper medical specialty in the 19th century. Names that continue to sound familiar to us today, such as Alois Alzheimer, Jean-Martin Charcot, and so many others, practiced the medicine of mind and brain, one and the same. In its infancy, neuropsychiatry lacked the sophisticated tools available to us today, making it difficult to elucidate the neurobiological correlates of cognition, behavior, and emotion. Theories of the mind diverged from the brain, in part through the advent of psychoanalysis led by Sigmund Freud, and behaviorism with B.F. Skinner, the latter who viewed the brain as, quote, a black box and almost irrelevant to scientific pursuit. I should add here, though, that Sigmund Freud was truly sort of trained as a neurologist and had a lot of interest in trying to find those biological correlates of human thought and emotion. But as I mentioned, he didn't have the tools at hand to do that when he wanted to. He was really before his time, and that drove him over towards more of the theories surrounding psychoanalysis and psychodynamics. With the prevailing models of the mind having little to do with the brain, along with a number of other historical factors, psychiatry and neurology became increasingly siloed from one another. It is said that this began an era of practicing mindless neurology and brainless psychiatry, but not for long. There remained footholds of neuropsychiatry in some pockets of the world, and slowly but surely, a chorus advocating for clinical neuroscience grew louder and louder, with Norman Geschwin and his students in Boston, the establishment of the American Neuropsychiatric Association in 1988, and the creation of an accredited neuropsychiatry fellowship. Fortunately, the instruments Freud and his contemporaries lacked are now at our fingertips. With EEG, we observe the patterned electrical dance that is our brain communicating within itself. With neuroimaging, we can peer not only into the structure of the brain's anatomy, but also its function. Genetics has revealed the complex ways our DNA blueprint influences our mental lives. Neuropsychology has localized regions to higher brain and higher order cognition. And neuromodulation, a more recent and quickly advancing technique, is used to both understand the brain and treat its ailments. Innovations in the field of connectomics, looking at the connectome of the brain, as they call it, a field dedicated to parsing diffuse and regional circuits throughout the brain, has allowed us to view into the architecture of neuroanatomy that once felt like the stuff of dreams. And these modalities, they all integrate, allowing us for the first time in our species' existence to begin to grasp how neural networks create a conscious life. And perhaps most importantly, by doing so, we will better be able to improve people's lives and to treat complex neuropsychiatric conditions. Here at UT Southwestern and the O'Donnell Brain Institute, neuropsychiatry is something of a framework that we use in education, in clinical care, and really in our institutional organization. In addition to having a behavioral neurology and neuropsychiatry accredited fellowship, UT Southwestern is one of only 4 residencies in the United States, which allows resident physicians to train in an integrated, combined program for neurology and psychiatry. These combined residencies and the fellowship that I mentioned earlier, these are all pathways to practicing neuropsychiatry, to equip physicians with the knowledge and the skills needed to diagnose and treat disorders that fall at this interface of the 2 fields of neurology and psychiatry. Be it the management of, let's say, as an example, paranoia in someone living with Alzheimer's dementia, or hallucinations in someone with Lewy body disease, depression in someone with epilepsy or after a stroke, or the persistent brain fog that you're familiar with from earlier talks following a traumatic brain injury. Neuropsychiatric training, it bridges the chasm of these 2 specialties, really with the aim of improving health outcomes for patients and their loved ones. The O'Donnell Brain Institute, it's home to the clinical neuroscience disciplines with psychiatry, neurology, but so many more. Our colleagues in neurosurgery, physical medicine and rehabilitation, and neuropsychology, all collaborating in patient care, research, and the training of future leaders in this field. This, I would argue, should really serve as an exemplar for healthcare systems across the nation, really due to its ability to unite so many areas of expertise and different approaches to patient care. We've been discussing quite a bit about what neuropsychiatry encompasses. I also worry that the name itself might sound overly biological, neuropsychiatry. And I have spent a lot of time in the past several minutes emphasizing the study of the brain itself. But neuropsychiatry is not reductionistic. It should not and does not make any claim that the entirety of one's experience of illness or of recovery can be fully captured by even the most micro or macro level understanding of brain function. And any such claim would be at a substantial cost. We must explore one's psychology, the traits which inform how a person experiences themselves, the world around them, and copes with the provocations that arise throughout life. We must listen to the life story of those for whom we care, seeing not only a constellation of symptoms or diagnoses, but rather a story of illness within the context of a much larger and richer narrative. Social, cultural, and community identities are essential to seeing the person as a whole. Not even the most advanced technology can supplant the therapeutic impact of that. How might we apply a neuropsychiatric lens to Havana Syndrome, narrowing in on our scientific understanding and clinical care? The scientific and medical communities, as of yet, they haven't come to a consensus for a cause of the troubling symptoms captured in the early and ongoing cases of Havana Syndrome. There is an invested interest to do just that, with academic and government institutions committed to efforts that will hopefully shed light on precipitating and propagating factors. In fact, the intelligence community experts panel on anomalous health incidents, they released, or just declassified rather, this month, an executive summary of several findings. And they recommend the development of specific biomarkers that may need to be separate from the ones that we've been turning to and developing for our traditional conceptualization of traumatic brain injuries. And importantly, The panel also underscores an imperative for timely and robust data collection around reporting incidents, data that can be used to characterize and track onset, course, and correlation with clinical measures and outcomes. Complex conditions without a definitive consensus for their cause just so happen to fall squarely within the realm of neuropsychiatry. Characterizing the cognitive, emotional, and behavioral symptoms one is feeling and is devastated by may have the ability to point towards meaningful and effective interventions. It should have. While the expert panel's executive summary did not find evidence supporting psychosocial aspects alone explaining core reported features, psychosocial factors can absolutely influence symptoms and their course. The acute and chronic symptoms described in Havana Syndrome may compromise one's ability to occupy their typical roles, which can take a profound toll on social and professional identities. When someone has endured an event that compromises their ability to work in the same capacity to which they have become accustomed, or to be present in their family and friend networks, this can be an incredible threat to a sense of self, both self-esteem and self-agency, and risk worsening feelings of demoralization, helplessness, and possibly depression and anxiety, all elements of an illness experience that clinicians have to be hyper aware of for the individual. One condition which you have heard about in detail from Drs. Cullum and Lakritz that we encounter not uncommonly in a neuropsychiatric clinic is traumatic brain injury. Following a TBI, there is typically an acute course, and depending on the nature and the severity of the TBI, chronic sequelae. Cognition, emotion, motivation, balance, sleep, and several other neurobehavioral domains may be affected. And reported symptoms of Havana Syndrome, at least in part, overlap with what we've traditionally referred to as post-concussive symptoms of TBI, including subjective concerns for dizziness, headache, cloudy thinking, impaired memory, and irritability. In TBI, when there is at least a closed head injury, there can be focal injuries to specific regions of the brain, sometimes what we hear called coup and contra coup. And if the impact is with enough force, the results of those injuries may appear on neuroimaging, structural imaging, like a CAT scan or an MRI scan. But for the majority of TBIs, clinical images do not detect lesions or other signs of injury. This is a result of the damage that's being done on a much smaller level, affecting the integrity of connections throughout the brain, leading to inflammation, oxidative stress, and dysregulation of neurotransmitter systems that modulate neural activity. It remains unknown at this time to what extent TBI may or may not be a model for discovering the mechanisms of Havana Syndrome, but the treatment of those with TBI at this time, I believe, can be incredibly informative. A common thread to successful treatment is a multidisciplinary approach, and I can't emphasize this enough. With complex conditions, rarely does a single clinician have the ability to alone achieve all the goals of a holistic recovery care plan. It really takes a team. Depending on the symptom cluster and the functional challenges that one may observe in their assessments, medications may or may not be indicated. At the foundation of treatment, though, is a collection of therapists with different areas of rehabilitative expertise. These include psychotherapists, specialists who work to identify the connections between thoughts and emotions and help with the development of healthy, adaptive coping mechanisms. Cognitive rehabilitation with therapists who develop and design and implement strategies for neurocognitive training, focusing on domains like attention, executive functioning, and memory. and to help the individual compensate for areas where they are noticing more of a challenge. Physical therapy, including, as the literature has described, vestibular therapy for those with triple PD, or for matters of gait and other ambulatory barriers. As stated in the IC experts panel, their executive summary, the one I alluded to earlier that was declassified just a few days ago, those affected by these incidents, quote, deserve the best possible care, as well as appreciation for their sacrifices. When I read this closing paragraph of their summary, it reminded me of a famed lecture, a lecture that was given by Dr. Francis Peabody to his medical students in 1926. Dr. Peabody said, time, sympathy, and understanding must be lavishly dispensed, but the reward is to be found in that personal bond which forms the greatest satisfaction of the practice of medicine. One of the essential qualities of the clinician is an interest in humanity, for the secret of the care of the patient is caring for the patient. And I so very strongly believe that this sentiment captures the most important ingredients of neuropsychiatry. With that, I just want to say thanks to everyone again, to our panelists, to our hosts, and to all of our guests. And I would be happy to take any questions and have a conversation.
Well, thank you, Dr. Lane, for your excellent presentation. We have a question from Scott Sanan, who asks, considering your comments on applications to TBI, what is your opinion on the potential applications of neuromodulation for patients with Havana Syndrome or anomalous health incidents?
Yeah, that's an excellent question. And there has been a growing body of literature looking at the role of neuromodulation, transcranial magnetic stimulation, or TMS, looking at its role in affecting benefit for different cognitive deficits. This has been studied in patients with neurodegenerative diseases like Alzheimer's disease or Parkinson's disease. In fact, in the FDA-approved paradigm that's used for treating depression, TMS targets a part of the brain called the dorsolateral prefrontal cortex, or our DLPFC. Now, the DLPFC, traditionally in fields of clinical neuroscience, has been thought about as a major cognitive hub, part of a frontal lobe and subcortical network responsible for complex attention and working memory. So the fact that targeting the dorsolateral prefrontal cortex has benefit for patients with depression is very interesting. And there's a paper out just last year in 2021 by a neuropsychiatry group and a neuromodulation group at Brigham. And it identified a lot of overlap between the frontal, parietal, and subcortical networks that we think about subserving so much of a cognitive function, that network overlapped to an extraordinary degree with a network implemented in depression. And this is across patients and across different diagnoses. These were patients with neurodegenerative disorders. These were patients with traumatic brain injuries. So this idea that neuromodulation could potentially play a role for easing the cognitive challenges that patients experience, regardless of etiology, regardless of the cause, I think is an exciting development and one that we need to explore further. And its application to Havana Syndrome may be a very real and active research question in the near future. Great question, thank you.
Thank you. We have a question from Dr. Len Baer. He writes, Dr. Lane, thank you for a comprehensive presentation. In it, could you mention ongoing cases of Havana Syndrome? And could you expand on it, please? Did you mean ongoing assaults or post-assault lingering conditions? Thank you.
Yeah, thank you. An important clarification. That was those who have already endured these assaults, these incidents, and have protracted chronic sequelae, symptoms of that. Important distinction. Thank you. Yeah.
Thank you.
One other thing I'll add, Dr. DeCleva, is that there was some interesting and an important preliminary work that had happened, and Dr. Lakritz and Cullum may have spoken to this, looking at imaging findings in index cases of Havana Syndrome very early on that were published in JAMA, I believe. And I think that this was laying a groundwork for a lot more research on the biological mechanisms potentially underlying this constellation of symptoms as it relates to brain networks. And in clinical neuroscience, historically, we've talked a lot about regions of the brain. This region might be slightly smaller in volume, or this region slightly larger. But an exciting and cutting edge opportunity for anyone that is involved with the clinical care or research of complex brain disorders of neuropsychiatric illness. That an active area where we need so much more effort placed is learning about the network functioning, to think about the brain as a collection of focal and distributed networks, and to analyze how those networks interact with one another and within themselves, both in states of health and in states of illness. And Havana Syndrome may be, possibly, it may be a candidate for those very types of studies.
Thank you. We have a question from Patrick Alavi. Dr. Lane, thanks for the great presentation. Is there any evidence for radio frequency interference in brain activities?
Excellent question. So the executive summary that was declassified, the panel made comment on this. And I believe, I don't want to misspeak, but I believe the language that they used was that in their opinion is that radio frequency energy could potentially explain some of the symptoms that were reported and experienced by those early and latter cases of Havana Syndrome. And there has been literature around what kind of impact radio frequency, particularly pulsed radio frequency, can have on neural function, notably in animal models. I won't claim to say that I have a wealth of expertise about that specific area or question, but that there has been a smattering of evidence to show that pulsed radio frequencies could affect the brain's activity in a way that might reach clinical thresholds.
Thank you. We have a question from Dr. Chris Gilbert, who is a senior writer and editor for Psychology Today. Welcome, Dr. Gilbert. Thank you for attending. She asks, how many of the Havana Syndrome victims had MRI abnormal findings with white matter changes? And there's a follow-on question from Dr. Cullum that kind of goes in that direction. What is your impression of the white and gray matter differences reported in the Verma et al. 2019 study?
Great question. I don't have the exact numbers in front of me to speak to the exact numbers, but what I'll say is that those studies laid an important groundwork. But in terms of how do we interpret those studies and how do we relate them to our clinical understanding, I think we know we need more research. And I say that because our sample size in part was quite small. And it was difficult to say about baseline imaging results. And it is challenging to find what would be the most appropriate control group without a full understanding of the index cases, those who had been treated for reported Havana Syndrome. And the reason that is important is because obviously a lot of information was still classified at the time. So it's hard to match completely for not negligible factors around demographics and so forth and so on. Medical comorbidities would be a really important factor that you would want to have at your hands to match groups. Because if one group has higher rates of cerebrovascular disease, they're also likely to have higher rates of, cardiovascular disease, they're also likely to have higher rates of cerebrovascular disease and so forth. So there's some methodological challenges to those early studies that make it very, very, very difficult to extrapolate the sort of key abstract sentence, which is that there were differences, but there's a lot of nuance behind that when you dive deep into the methodology of that work. Yeah. And I think that the authors and researchers who did that work, they were working with what they could have access to. And so they were obviously thoughtful about the design of their study with what they had.
There's another question here. If radio frequency can hypothetically be used to disrupt cognition, is there a simple test distinguishing between cognitive impairment and other neurological brain dysfunctions, such as those that have been discussed today?
Excellent question. So there are lots and lots of different assessments that we can do. And my colleagues, Dr. Cullum and Dr. Lakritz, they have an enormous category and library of different assessments that they can give individuals and then compare the results of those tests to normative data, which oftentimes includes things like the individual's age and their educational background, and to try to tease out, does that person perform in any given cognitive domain, be it memory or attention or visual spatial perception, whatever the domain may be, does that individual perform within the range we would expect compared to those normative data for that individual's age and educational background and other factors? Or do they exceed those expectations, or do they fall below those expectations? And what I do as a neuropsychiatrist in working with patients who experience cognitive symptoms that are transdiagnostic, it may be that someone has difficulty recalling information because they have Alzheimer's disease. It may be because someone has Parkinson's disease. It may be because someone had a stroke and just a particular part of their brain that has led to an amnestic syndrome. Sometimes we can use the patterns of those results to point us in the direction of a certain syndrome or point us away from the direction of a certain syndrome. Very rarely do our tests give us a definitive, clear-cut, yes, this is the cause of your cognitive impairment. It can demonstrate to us where the cognitive impairment is in terms of what areas of thinking and memory might be affected. It might be able to tell us whether there's been a decline over time if someone has a series of tests. And it can give us clues as to potential causes. But to really tease out a cause, or what we call in medicine an etiology of a symptom, we have to take the whole clinical picture. We have to piece together the history, the onset, the course, and all of the data that we're able to collect that may span cognitive testing, neurological examination, blood work, and imaging findings. And to use, let's say, Alzheimer's as an example, over the course of decades, we've been able to develop a repertoire of clinical measures that once all of those are gathered together, biomarkers from imaging or spinal fluid, examination with paper and pencil testing, the history, family history, once we piece all that together, we can pretty confidently say we think this is the cause of your memory loss. But that takes decades of research and development to be able to have confident, sensitive, and specific markers to give that guidance to patients.